Good evening, everybody, or good afternoon, good morning, whenever you're listening to this broadcast later on. My name is Dr. Colin Bartoe. I'm with the Central Florida Wellness Council here in Orlando. Today we have with us Dr. Andrew Walsh. He's a acupuncturist, educator, and just all-around brilliant individual. And today's topic of post-surgical scar tissue is something that I'm very, very excited about. It's something that I get to work with on a regular basis, and as soon as Dr. Walsh and I started talking about this being a webinar topic, I got really excited. I like hearing other people's takes on this, and I like educating people through different viewpoints. So, by the way, real quick, do you see any flashing going on my end or no?
No.
Okay.
No. A little tiny to your right, left, I think, the open window.
Okay, yeah, I've got the open window, but for some reason my computer screen's fine. All right.
Yeah.
So while we get started, let's just go ahead and have you give us a little bit of a background on what your training is and your experience with post-surgical scar tissue, and then we'll dive into what it is and how it affects us.
Okay, great. Thank you, Colin. Thanks for having me on today. When we did speak a lot, we both deal with scar tissue a lot, and we see the impact it has on many patients, though many of them don't realize the impact. For me, I got involved in the treatment of scar tissue early on in my training. I went to a seminar and they were discussing scar tissue. My specialty is acupuncture. And that kind of opened my eyes up, and then really been working with it for a long time since. But my background is acupuncture, and that's really the main medium that I'm using scar tissue. Of course, with acupuncture, people come to you for so many different reasons. Usually, like chiropractors often, come to us after they've tried everything else and haven't been successful, and looking for something different. And so many times, I've found that often scar tissue from a previous trauma or especially operation can be actually underlying cause to many problems, metabolic or physical, and most people have no idea. Usually 5 to 10 years after the operation, people begin to get symptoms, and because it takes so long, no one's diagnosed or assessed to see if that scar tissue is affecting them anyway now.
Nice. Okay. So you actually get quite a few patients after surgery that don't really understand what's going on, is kind of what we gathered from this and other conversations that we've had. Is that true?
Yeah.
Okay.
Yeah, true. And usually most people, though, they're not coming to you for an adhesion. A lot of people don't always come to me for adhesions, or for the operation. Often they're coming for other reasons. And often there is an adhesion that can be the tracing as a cause of a problem. So usually it takes often 5 to 10 years for the symptoms to actually appear before people even symptoms manifest. So yeah, so often, yes, sometimes they're coming in specifically after an operation or an accident, but more often, no, they're not. They're coming in for some other related problem.
Awesome. So
yeah,
we've got a bit of a 10,000-foot view. Let's take it down and talk about what exactly happens. What is the scar tissue adhesion, and how does that affect us? So when we're looking at this, obviously anytime we cut into the body, we're damaging tissue, we're separating tissue, and the healing process naturally involves scar tissue. Can you go into what the difference is or what the focus is in that for the adhesion, as we call it?
Right, and just as you were saying, that's right. In an operation, the adhesions are formed because you're cutting through the different layers of muscle and fascia, and afterwards the different layers bind back together again, and that's a normal state of healing. And collagen's laid down, and over a period of time, that collagen's made into a better collagen, and it all heals. The different layers of the muscle and fascia, if they're healed separated, then you have no problem. When an adhesion occurs is when those different layers that have been cut through heal stuck to another layer. So the scar tissue forms between the layers. So instead of the muscle and fascia being able to move smoothly over each other and with each other, they're now stuck.
Okay. And
so, yep.
Go ahead.
Well, that's one kind of adhesion, and often what is caused from an operation or a trauma, for example, that involves blunt force with a lot of physical damage or damage to tissue. And then there is another type of adhesion that is actually very common as well, is from inflammation. Adhesions coming from an inflammatory event occurring, such as gastroenteritis, ovarian cysts, salpingitis, inflammation of the fallopian tubes, and such things. But back to the physical scar tissue.
Yeah, and I mean, it's important to mention that these adhesions between different layers of fascia and muscle, I mean, they can happen from a number of different things. Today's topic is more specifically just about post-surgical scar tissue.
Right.
But what are some of the things that you actually see people suffering from years after these surgical interventions, once these adhesions set in and have had time to begin to create these symptoms?
Yeah, so there are certainly some general, looking at operations, for example, there are certainly some certain operations that generally will create particular types of symptoms. So if we look at a cesarean C-section, for example, some of the common symptoms that will appear 5 to 10 years, even 15 years, depending how much adhesion is there in the first place, and depends upon the health of the individual and what other life events, health events may come in to actually bring some of these problems out. But some of the most common symptoms for them is repeated bladder infections. Where the tissues have adhered together, just because normally these tissues are moving fluidly over each other without any stress or tension. Now they're stuck together, and just through body movement, that there's irritation and inflammation caused because of the pulling or the friction of these two stuck tissues that normally move freely over each other. Now, this is why it takes so long. It may be a very small adhesion that is only creating a very small amount of inflammation and irritation on daily movement, but it's the accumulative effect of that occurring for 15 years. And that small, low-level inflammation may start to build up and just create a general inflammatory response. So it weakens the immunity. So there's always an immune response occurring in that pelvic area. And then it weakens the immunity in that area. Also weakens the kidneys, the adrenal glands, because it has to deal with this low-level inflammation occurring over a very long period of time. So a bladder infection can occur because of just that inflammation spreading in those areas. It also often, lower back pain can occur, and that's more if there's a structure is being pulled. It may create a physical bias. And then the other thing is quite often with cesarean C-section, interesting enough, is the neck pain, actually.
From a cesarean, you actually see a lot of neck pain.
A lot of neck pain and general neck pain, general tension. And that comes, often what that comes from is the low-level inflammation that's occurring over a long period of time is creating an immune response that is triggering, which also triggers cortisol.
Mm-hmm.
The cortisol starts to exhaust the adrenal glands, and then when people are getting tired and tense, stressed out, the adrenals get deficient, neck tension and a lot of general neck tension and neck pain occurs, which is very hard neck tension to treat because a lot of muscle tension, but you can never release it. It always comes back, and of course you always see symptoms associated with adrenal fatigue and or autoimmune diseases, and this is another problem. You really have three major problems from adhesions and scar tissue. First of all, you have the physical adhesion that can block local blood, nerve, and lymph flow because your blood, nerve, and lymph are flowing between these tissues. That's why they're meant to be free, because not only are the fascia and muscle there to move across each other freely, but also blood, nerve, and lymph are flowing between those muscles and fascia as well. Now, if they're stuck together, they can stick to blood and lymph. So, for example, with a bladder, a C-section, you can get, the first problem can be an impairment of some blood, lymph, or nerve to the bladder going through that area. So maybe some inflammation, repeated bladder infections, which keep occurring, and no matter how careful the woman is and what she does, they keep coming back. Also, after about 20 years, we start to see weakness of the bladder, incontinence, difficulty with holding the bladder, and of course that happens, usually some other events occurring. That usually occurs after they've had years of reoccurring bladder infections, reoccurring medication to treat those bladder infections, multitudes of tests to find out what they are, and then continuing on, until then it leads to further and further and further. So there's that impairment of circulation, nerve or limb function. The second problem is this irritation that I mentioned earlier, creating some inflammation, and that low-level inflammation causing a depletion of the adrenal glands because of the excess production of cortisol, and constant low-level stimulation to the immune system, which is going, what is wrong? What is wrong? Where is this inflammation? Why can't we fight it? Is there an infection? For the last 15 years going on. And eventually it gets confused. Then we have an autoimmune disease, which of course, fibromyalgia, chronic fatigue, there's so many of them, which is so common too. And of course, the third problem, mentioning restriction of nerve blood flow, second, low-level long-term inflammation and the problems it causes. And the third problem being, I mentioned, structure. So if the adhesions physically changing the physical structure of the body, putting the spine out, putting the hips out, et cetera, So part of that initial assessment is to find out which one or all or none is this person experiencing, and then tracing that back. So, for example, the cesarean C-section, we're often looking at those bladder symptoms. Now, when we generally assess the adhesion, the scar tissue, often we can tell if there's a lot of inflammation. If we're getting in this inflammation and we start to get to a autoimmune problem, is the scar will be red or a dark color than the skin. Normally a scar will be a lighter color, slightly lighter color, but it should never be darker, a dark color. Shouldn't be red, inflamed. And if it is, there's a problem. Now, of course, 6 weeks, up to 3 months initially after an operation, of course, you're going to go through that stage. But we're talking about when you look at a cesarean C-section scar that is 15 years old, and it's red, it's inflamed, it's raised, and it's painful to touch. The interesting thing is, in most of these circumstances, the individual patients don't feel a problem from day to day with it. The body's at this low-level stimuli, the body's very good at ignoring it and shutting it off. It's like the stone in the shoe. You walk around with a small stone in the shoe, it drives you crazy. But of course, if you hit your thumb with a hammer, you forget about the stone in the shoe. But if it's very low level, your body compensates and ignores it over a period of time. But often so many women are aware there is some irritation there if they touch, or it gets red, or sometimes certain trousers will irritate them, etc.
Yeah. I love the fact started with cesarean section as an example. And the most common thing that we find coming in for is not the itself.
No.
It's one of my first papers, and I got out of school. Can you turn your volume down just a little bit? I'm getting some feedback through yours.
Gotcha.
Perfect. Okay. So one of my first patients was a young woman, who had an appendectomy. She had her appendix removed when she was probably 10 to 12 years old. And I met her when she was in her mid-20s. But in the time between that surgery and the time that I had met her, she had acquired menstrual cycle problems, digestive issues where she was not passing solid bowel movements. She had weakness in the abdominal muscles. She had pain when she was trying to exercise, her low back and things like that. So when I started working on her, it just came up in conversation that she had this surgical procedure done. And as we explored further in, we found that these adhesions stretched all the way from the superficial skin layer through the fascia, through the muscle, into the ovaries, into the intestines. It was just a huge mess. And once we were able to open those adhesions up, she actually regained a menstrual cycle, was able to pass solid bowel movements and those types of things. But those were never things she associated with the scar. So
Absolutely, yeah.
like you were saying, it's very important that people understand it's not, cut and dry. It's not this equals a scar.
No, and that's part of, you have to do an assessment. You have to know what you're looking for. And in most, like the first part for an assessment.
Keep going. I'm just getting a flash. My battery's dying. I got to plug in real quick.
Okay, no problem.
Right, keep going.
So the first part of the assessment is of course, signs and symptoms, background history, etc., and information from the patient. But then is visually looking at the scar, and the scar, as I mentioned earlier, should be a lighter shade than the surrounding skin, or the same. If it is red or a darker, more like purple color, or depending, but a darker color can be brown, then that itself shows you there is already some type of inflammatory process occurring. And sometimes when it's a very dark, like a bruise or darker color, it's not inflammation, but actually a pooling of superficial microcirculation. It's actually dead blood there sometimes. It's like a pigment. Then the second part of the visual examination is actually looking at the contour of the abdomen. So, for example, for a C-section scar, standing as well as lying, to see the symmetry of the abdominal muscles. Is there an abnormal shape? Is it pulling down in where that scar is? Is the abdomen not symmetrical, etc.? So that's the second part. Then the third part is actually palpation, touching that and feeling for the temperature. And the abdomen should be the same temperature pretty much overall, from the sternum layer through down to the pubic symphysis. It should be pretty much the same temperature. It's actually meant to be can be slightly a little bit cooler below, but about the same temperature. So the second part is there, and often what you'll find, two areas, it'll be very hot over the scar area, or you can actually get it to be very cold, much cooler than the area, which usually indicates what you'll find is then on deeper palpation, you'll be looking for muscle guarding. So the next thing is to look, is that patient subconsciously, not consciously, but subconsciously, when you press on those abdominal muscles, the body will react and guard and tighten against your pressure. That is a problem. Muscles are there for three functions. First, for movement. Second, for the generation and regulation of heat in our body. And third is for protection. If we have an injury, we tighten our muscles to protect the underlying tissues or organs or glands. And it's especially true when it comes to our spinal muscles and our abdominal muscles. Obviously in the back, the most important thing is our spine. If there's something there, it'll tighten up to protect it. But in the stomach, it's our organs. So there's areas of abdominal muscles that are tightening or guarding it. It's usually a representation of something going underneath. So that's the second part, is the palpation. And then, of course, as you know, Colin, when you start feeling through there, when you have adhesions, it's a fibrous, dense tissue. Beyond that guarding, then you're looking at that feeling with that fibrous, dense tissue. And you can trace it, of course. You can, to a certain degree, where that's traveling. Is it going directly to the bladder? Is it shooting off around to part of the large intestine? This is the further investigation, which is unique to each individual in some respects. And that's the third part. Then sourcing the trace of where these adhesions are going and what organs they may be affecting. And often, to the patient's surprise, this is the first time someone has felt their scar since the operation. Most patients is like, well, yeah, it gets sore sometimes, or I feel an irritation, or I've noticed it's red, but it doesn't really give me pain. And you're the first person to actually even check it, But I check all patients, whether they come to me for an adhesion-related disorder, they know that the adhesion is causing a problem, or they're coming to me for chronic fatigue or fibromyalgia or adrenal exhaustion. And within that patient intake is what is past medical trauma, illnesses, or operations. So, of course, for any operation, the first part of the physical examination is to check those adhesions. Not all adhesions cause problems. Not all operations cause adhesions, I should say.
And not all operations are abdominal, which are our primary examples.
Exactly.
Yeah.
Actually, statistics like a large research follow-up in Australia on adhesion-related disorders, a government research, 93% of people who have an abdominal operation, including laparoscopy and keyhole, will form abdominal adhesions. That's a pretty big figure, which means if you've had an operation in your abdomen, you're pretty sure that it may be interfering with something.
Absolutely. Yeah. So at this point, I'd like to open up and take questions if there are any. If not, there's a couple things I'd like to talk to you more about. But if anybody does have a question from the audience, please feel free at this point. Looks like we got a caller right here. Quentin. Let's see while he logs in here. Looks like it's taken him a second to log in, so we'll chit chat for a second while that's happening. But yeah, to go back to what you were saying about blocking lymph flow and blood flow and all these different things, a number of my patients are athletes, and I get to see, surgeries from ACLs and surgeries from broken ankles and all these different things. And I've seen in a number of cases, darkening around the tissue or darkening of the tissue around the scars and things like that, swelling that's unable to be reduced because the scar tissue, those adhesions that are being formed, are blocking that lymphatic drainage. And one of the biggest things you have to do at that point is allow that tissue to open up so you can drain that back through. Otherwise, the healing process will be retarded. It will be slowed down. Yeah.
That's right. And with a patient who I find there are the signs that the adhesion is causing a problem. For example, there's inflammation going on there, inflammatory response to that scar tissue, and that patient has had that, for 10, 12 years. You have to change that before, giving supplements or anything to help with adrenal exhaustion will only be temporary Band-Aid. It will never be getting to the source of the problem. It's like having a hole in the bucket and you keep filling it up with water and still trying to keep filling it up with water. It's never going to solve the problem. You have to fix the hole first. Mm-hmm. Then the bucket will hold water. And I see so many patients with adrenal exhaustion and autoimmune diseases, and they have these inflammatory responses occurring all throughout their body for 20 years. And they've tried many things and they help. All these things will help with their adrenal exhaustion and fibromyalgia symptoms, but they never can quite get on top of it because they've never plugged the leak where their energy, or so to speak, is being depleted. Sometimes it's the first thing you must treat to fix many problems,
Absolutely. Yeah, it's becoming more and more prevalent. Let me just try one more time.
Mr. Gunn is still calling in? Yep.
It's starting and not connecting. I'm going to try to see here. But I don't know why it's not letting him in.
He looks like a fine gentleman on the picture.
Very well dressed. So with scar tissue, with adhesions becoming more and more prevalent, more and more of a topic of conversation, there's techniques out there that are becoming more famous, things like Graston, which does more superficial types of scar work, and they have techniques to do deeper as well. But there's a myriad of different techniques, and they're all effective in different individuals. And part of what I wanted to make sure we talk about tonight is the fact that while there are different approaches to treating these scar tissue adhesions, each technique is viable in its own right. So
absolutely, that's the right thing. There's so many good techniques to change it.
Yes, absolutely. Yeah. So I use my hands. You use, I'm sure, needles as well as manual work. And if there's anything I missed, please add that in. Sure. But yeah, I mean, as long as people are now becoming more aware of this, and
is a great tool. Myofascial release. I believe you do some myofascial release as well. Is that right, Colin?
I use a manual technique, so I use my hands to break up scar tissue.
Gotcha, right. And that's the key. This is the right thing. Mm-hmm. The scar tissue is normal bodily tissue. It's actually collagen that has been laid down in a rough, what they call rough matrix. Because initially, when the injury occurs, whether the operation or trauma, the body tries to heal it as quickly as possible and get all the tissues holding back together again. And it does this, and that's the 70% of the work done. And then over 30% of the work done, and then over a long period of time after the initial injury, the body comes back with macrophages and fibroblasts, particular cells in our body that are responsible for this, comes back in and rearranges this collagen, breaks it down, rearranges it, separates any tissues that have been stuck together, and puts the body back to its optimal state again, or close to.
Tries to, yeah.
Yeah, but sometimes it never finishes this job. The adhesions occurs, and there's many factors why one person will get more adhesions than the other, but it doesn't finish it. The great thing is we can stimulate the body many ways to come back and do this process and break it down and change that adhesion to a fair degree. Some depends on the level of scar tissue. But in most circumstances, a significant difference.
Nice. So, kind of getting closer to the end here, I want to try to keep these about 30 minutes so they're easily digestible as podcasts or quick watches on lunch break or something. It looks like we're not able to get our question in from Mr. Gunn. However, if there are any final thoughts that you do have or things that you would like people to be aware of, people to, to kind of take away from this, please share with us what you have, and then I'll send us off.
Well, look, the first thing is, if you've had an operation, if you had some type of surgery or trauma, seek out someone like yourself or myself, or someone who you know has some experience in understanding how to assess if it is a problem, and has a treatment that can actually repair it. Of course, surgery is the conventional option, and one that's not recommended by medical doctors as well, because of course it creates more adhesion and is only reserved for very serious problems such as a bowel obstruction or etc. But there are many viable options to be able to change this tissue. It must involve manual technique. You have to create some micro trauma at the site of the adhesion to stimulate this physiological response within the body to come back and create and initiate this repair process again. So it does, you can't take a pill for it. This is what I'm trying to say. There has to be a manual technique involved. There is no pill to take to change the adhesion. You can certainly take some supplementations that can support the process of the change or the repair, but a supplement alone cannot do it. There must be some manual technique involved, whether that be a Grafton technique, a myofascial release, or there are many other techniques. For myself, I use acupuncture. I use the needle. And of course, I deal with some fairly severe and deep adhesions. We don't insert the needles deeply, but because we're able to break through the surface of the scar, we're able to and create a micro trauma in that collagen. We're able to create a very big physiological process to start to break that down. I also use injectables as well that can enhance it as well, such as hyaluronic acid, vitamin C, and some saline, and some other different things as well.
Nice. Well, and another thing too is that this isn't a quick fix in most cases. It does take a little time to break it up and to allow Absolutely. The body to reinstate that healing process. Yeah. But it's been quite successful for both of us in our practices, and I just hope that everybody understands, there is hope, and even if things don't quite make sense, keep searching, keep looking for help, because it could be something like this.
Absolutely. And if you haven't, go and find out, have a look, because if it hasn't been ruled out, then certainly you need to look at it, and make sure that's not an underlying problem why you still have an issue that you can't seem to get on top of, or any medication or supplement you take is still not working.
Absolutely. Well, yeah. Dr. Walsh, thank you so much for joining us today. It was a pleasure.
Thank you, Dr. Bartoe.
And I look forward to working with you more in the future.
Yes, absolutely.
All right. Thank you, everybody else, on behalf of the Central Florida Wellness Council. And please join us next month for our next installment of the webinar series. Enjoy.